That is what I love about interventional radiology. Bread and butter is so different every day. So we're one of the specialties that cover everything from literally head to toe.
Dr. Mark Lessne, how are you doing, my friend?
I'm doing great. How are you?
I'm wonderful.
I love the haircut.
Thank you. Thank you. Fresh, just for you.
Mm-hmm.
We are joined by 600 of our closest friends from around the globe with us tonight, talking all about a very cool specialty, one that I think a lot of students will love, a little bit more hands-on-y, a little bit more visual, some vascular interventional radiology.
Yeah, absolutely.
So I'm excited to chat with you.
Yeah, thanks for having me.
Let's start. One of my favorite questions that has come about through eShadowing is, what is bread and butter for vascular and interventional radiology?
Yeah, that's a great question. That is what I love about interventional radiology. Bread and butter is so different every day. So we're one of the specialties that cover everything from literally head to toe. We treat stroke all the way to gangrene of the toe. And so in a single day, our bread and butter could be opening up someone's blocked arteries in a leg, could be draining an infected biliary system, a liver that's backed up, could be reconstructing a portal vein through a little small hole. It could be treating varicose veins for a 50-year-old truck driver in an outpatient setting. Could be going to clinic every day. It's a lot of diversity, which I really like.
Wow, that's interesting.
Yeah.
So for vascular interventional radiology, can you go, you know what? I just love varicose veins. I want to be known as the varicose veins guy, right? I'm going to market myself as varicose. I'm trying to think of a cool name that starts with V, and it's just not coming to me. Varicose Vinny. Like, I'm varicose Vinny. You come see me.
Yes, you want a Vini Vidi Vici with the veiny.
Yes, exactly.
You can. So, you asked sort of the bread and butter. Yeah, within that, there's some people who mostly do one thing or another. So one of the big things in interventional radiology would be like interventional oncology. So we have interventional oncologists who mostly focus on the treatment of liver, kidney, lung cancer. There's certainly people who do vein disease, treat only varicose veins or DVT or some weird deep venous disease that may be less well known to medical students. So yeah, you absolutely can concentrate with, especially neurointerventional. I only treat head, neck, aneurysms or stroke, things like that.
Yeah, very cool, very interesting. So talk about. I think a lot of people understand what a radiologist is.
Yeah.
And then there's this interventional radiology. I thought radiology, you just sit in a dark room all day long and don't what is this field?
Yeah. I'm from Florida. I can't deal with darkness. It's got to be sunlight and bright. So interventional radiology or vascular interventional radiology is a little bit of a, sort of best kept secret in my opinion. So, and part of that is historically, I don't think we did a great job. So historically, we were diagnostic radiologists who then broke away to do procedures and be clinicians and sort of, take care of a patient from a medical standpoint as well from a procedure standpoint. And then that kind of got weird because like you said, diagnostic radiologists are one specialty and sort of interventional is a little bit of a difference. So recently they did change the training so that you match directly into interventional. But yeah, so interventional radiologists are not sitting in a dark room. They are minimally invasive procedure specialists. So anything that can be done through a small hole using the body's natural pathways, in other words, their arteries, veins, bile ducts, lymphatics, to get to and treat disease, that's what we treat. We also can manage the patients who have those diseases. And so it's a very different specialty than diagnostic radiology, who is just interpreting images, very importantly, but very different.
So for someone who gets lost driving around, is that a skill directionally challenged? Is that a skill necessary for interventional radiology? Like, I got to this fork in the iliac artery. Do I go left here? Do I go right? I don't know what's going on.
Yeah, sort of the turn at Albuquerque kind of thing. Yeah, so if you ask my wife, I think she thinks I'm a pretty good interventional radiologist, and she thinks I'm a terrible navigator. So no, they're not mutually exclusive. Absolutely. Good. And the reason is we use image guidance. So, the whole creation of interventional radiology was, instead of filleting someone open with surgery and directly looking at that, you can go through a small hole through almost literally any part of the body from the head to the toe, and use image guidance, whether it's X-ray, CT, ultrasound, MRI, to try to find your way inside the body, but only through a small hole rather than actually looking at the whole thing in front of you. And
nice. Yeah. I see a comment here. Dr. Gray's lips look cold. I'm freezing. So they probably do look cold. I'm in my basement. The heater's on, but I'm freezing.
Yeah.
So
we'll get a pulse ox on him. Don't worry about it.
It's okay.
It's fine.
Yeah, it's remnants. I got my second Pfizer vaccine on Saturday, and it hit me like a truckload. Just flu-like symptoms Saturday night, Monday. Oh, luckily
it's all about hydration. I hydrated so much for my second shot. Yeah. I went to the bathroom 8 times, but no symptoms, no side effects.
Yeah, good to know. So I think an interesting thing for everyone here is the fact that obviously 674 people aren't all going to go into interventional radiology. Yeah. Some of them are going to go into general surgery and then do a fellowship in vascular surgery. Mm-hmm. Some of them are going to go into neurosurgery. Some of them are going to go into other fields where vascular and interventional radiology is starting to creep into those procedures that they potentially have historically done. Talk about the ramifications of multiple specialties now doing the same thing and what the future of that looks like.
Yeah. So a lot of times it's the other way around, that a lot of specialties are actually doing things that interventional radiology has historically done. And the reason is we are victims of our own success. And actually, I'm not even going to say victims. We are champions of our own success. And the reason is it has been so successful, these minimally invasive aneurysms. So the bottom line is you have multiple specialties that may treat the same thing, but that's not unique, right? So if you need back surgery, you could go to an orthopedic surgeon. You can go to a neurosurgeon. They're in the same space. And I always say, if you are, by the way, I love the shirt. That's exactly the point I'm about to make. If your focus is on the patient, I don't care who you are. You could be a psychiatrist. If you're well-trained and you know what you're doing and you care about the patient and doing the right thing rather than just doing a procedure just because it reimburses well, I will support you 100%. I don't care what specialty you are. Now, that said, I do like that as an interventional radiologist, a lot of the skill set I use for artery disease, I also use in the bile ducts. I also use in the lymphatics. I also use in the kidney. And so I sort of get to use my minimally invasive skills broadly. And that really makes me, I think, better for it.
Yeah. What led you down this path?
Yeah, obviously I get that question a lot. I was one of those medical students that loved everything. So I did OB and I'm like, oh, I want to be an OB. And then I did peds. I'm like, oh, pediatrics is where it's at. No question. And then I did surgery and so forth and so on. And so, radiology, interventional radiology, you got to keep your hands in every organ system. I mean, literally, I will open a fallopian tube. I mean, that's a procedure I do for women who are infertile and their fallopian tubes are blocked. I'll open a fallopian tube. And then the very next, procedure, I may be opening someone's SVC or closing down a bleed from a trauma patient. And so you kind of get your hands on every specialty. And I'm also very social. And I like the fact that I get to be on the phone with an OBGYN and then hang up and talk to the trauma surgeon. And we all collaborate together. And it's kind of a neat way to keep your hand in every part of medicine to some pretty great extent.
Yeah. Awesome.
While doing awesome procedures.
Yes. And not getting lost along the way.
Exactly. No. Need a map.
Let's go ahead and jump into your slideshow. I know you got a lot of awesome slides with some and stuff that we can dive into as well.
Yeah. So, if you'll indulge me, there's a minute video that actually could have, what you talked about in terms of other, specialties and doing things, what historically we did. I think this is a kind of a cool video. Then I'm going to see if it'll share it with you. Can you see my screen?
I can. I see
Okay.
black from where the video is.
All right.
Oh, there we go.
Let me show you this here.
Yeah. You want to click hide on that bottom bar there?
This man is in pain. All right, let's get started. Now the smaller inner catheter goes in and is advanced over the guide and down through the narrowing. Usually there's little resistance. Because of its safety, simplicity, and effectiveness, transluminal dilatation now qualifies as treatment of choice in the management of atherosclerotic stenosis. Its further improvement seems inevitable.
So that was Charlie Dotter, who's the father of our specialty. And this was him on Life magazine. He was known as Crazy Charlie because he was coming up with all these ideas that no one had ever thought of that were quite frankly heresy. And he said, no, I think it can work. I think I can do through a pinhole what y'all are doing with surgery. And one of the things I love is sort of this note from 1964, surgeon feels we have nothing to offer. And then Charlie's note, which is, by the way, I went ahead and treated the patient and she's doing great. And this is Laura Shaw, who's the patient who was treated, and she ended up saving her foot. And so, to be honest, I'll stop my screen share for a second. 50 years later, I swear to God, I still have referring doctors. I explain to them what I'm going to do for a patient who otherwise was told no options, it's hopeless. I explain what I'm going to do, and they go, "You're crazy. That's a crazy procedure." 50 years later, and it works, and we do it. I say, I'm going to go through the person's spleen. I'm going to open up their chronically blocked portal vein. I'm going to create a shunt between their hepatic vein and that newly open chronically occluded portal vein, and that's going to cure the patient's bleed, their esophageal varices. And they're like, that's crazy. But that's what we do as interventional radiologists. So I think Charlie Dotter set the stage for sort of what we do now. No question.
What do they find crazy about it? Because to me, it seems like construction, right?
100%.
It's like, hey, this road is backed up. Let's make a new road. Okay, easy.
And that's the analogy I give all my patients. I'm like, you're whatever. Artery vein is a highway. It's blocked. I need to open it. I'm a plumber. That's what I do. Yeah. And we find creative ways to plumb. So,
Yeah, I don't know if you saw this recently or if it's been talked about in any journals, but I saw a video recently. I think it was out of Russia, a new, and I don't know if this is old or new or whatever, but it seemed like a new technology that they're looking at that can go through, and we have some of this technology, I know already, where we block off kind of downstream effects so that we can clear occlusions and stuff so that we're not throwing plaques anywhere. But it's kind of a double-ended thing that opens up and then a little drill that goes in and clears out all the plaques and all that stuff. Is that something that you guys do or would do in the future as well?
Yeah. I'm sorry. You asked me why I went into interventional radiology. I guess I forgot another important thing. I like playing with toys. And so we get a ton of new devices. And, every week I get a phone call from a rep who's like, all right, I got this new device. It's, it's going to be something crazy to me. And sometimes it's same old, but sometimes you're like, oh my goodness, I can't believe I've never seen that before. And we get to try it and we get to use it. And absolutely, we get to roto-rooter and clean and do all these crazy things. Intravascular vacuum cleaners. I mean, we do all that stuff.
Where's the limit? How do we have a limit of what our vessels will withstand? I
mean, there is a limit. One way or the other, but I am nowhere near presumptuous to say I know the limit of what technology is going to bring us. And that's the beauty. I think if you talk to any interventional radiologist who's practicing today, they will tell you that they routinely do procedures that they did not train on. They just had to learn because it's new. Or that they routinely do procedure, not routinely, but they will at least do a procedure once every couple of years that's sort of never been described before. They just kind of pieced it together. And there's a lot of MacGyvering in interventional radiology. And what I loved about it is, I remember when I was a first, fellow and then a first couple of years attending, people would come down and say, Mark, I got a patient who has this. And then they would stop talking. And I'd be like, okay, what would you like me to do? And they're like, yeah, we don't know. Figure it out.
Yeah.
And that's what we have to figure it out. We talk to surgery, we talk to medicine, we talk to whatever. No one GI, no one has anything to offer. Is anything you can do? And the answer almost always is, yeah, let's try something.
Do you think, and this is just me being interested,
yeah,
we're getting to a point now where technology is getting cheaper and cheaper. Things are getting faster and faster. Hopefully we'll have technology where every year I can get a quick MRI of all of my vessels and go, hey, like my risk of a heart attack is going up too much. Yeah. I'm just going to go in and clean everything out, right?
Yeah.
There's going to be a clinic, right? You go to your colonic clinics where they stick a tube up your butt and clean you out. But there's going to be a clinic where you pop a catheter in my radial artery, and an hour later, I'm good for 5 years.
Yeah.
Right. Is that the future?
Better primary prevention with maybe a medicine or something like that. I think they're probably going to sort of take the lead. But at the end of the day, I mean, there is tons of research to be done in interventional radiology. We have been, you look at oncology, okay? They mop the floor in terms of research and data and sort of evidence driven. And every other medical specialty, where most other medical specialties are sort of just trying to keep up. And so interventional radiology, I think one of the other appeals is there's so much opportunity to prove what we're doing is the right thing.
Yeah. It's interesting. One of the questions that just came up is a problem-solving profession. This is very fascinating, right? What if I don't think outside the box like other people? Is it a profession that I should go into? Is that a skill that you learn? Or are you one of those people or you're not?
I learned pretty early on the way to become smart is surround yourselves with smart people. And so when you surround yourself with interventional radiologists, you're basically bathed in MacGyver problem solving. And so, no, I do not think you have to have an intrinsic ability, because you will literally at every turn be exposed to people who are thinking about this all the time, thinking of different ways. And I've been in practice, 10 years now. Clearly, my mind works differently than it did 10 years ago. Some ways good, some ways bad. But it works differently, and it can absolutely be a skill. I think in terms of what you have to have, I use the term, I used to have 8 fellows a year I would train. And I would use the term, you can't be lazy in thought. So that's okay if you can't do something or another, but you got to try to think about it. So if you're a person, which none of our 600 plus people on are, but if you happen to be a person who's like, I just sort of want the answer given to me, this probably isn't for you. You got to have some time to think. Yeah.
It's one of those fields where very similar to medicine in general, right?
Yeah.
You can't diagnose something you've never seen.
Right.
And in your field, it's like, well, I can't think of something I've never thought about or even seen. But if I see a case study, well, like, wow, I can now take that same thought and translate into these 10 other cases that I'm going to see in the next few weeks of like, I never would have thought about that.
100%. I'm telling you, it is amazing how some IRs, interventional radiologists, think in terms of, I did this once in a vein in the arm. So I'm pretty sure I could do this for the middle cerebral artery. I mean, it is like or in the liver. Uh-huh. The application is unbelievable. So literally, there is a technique I use to treat patients with cirrhosis in the liver that I also use to create a fistula in the leg. Mm. I mean, it's the same sort of principle, part of the procedure. It's just application, like you said.
Oh, I would have loved IR. That's just my brain thinks like that. That's just how my brain works.
Come on, it's not too late.
I'm a podcaster, darn it.
All right, fine. Fair enough.
Very interesting. All right, let's get back to your slideshow. What other good stuff do we have here?
Yeah, so let me see what else. So I'll share my screen again and turn that on. That is pretty easy.
So one question that came up here is, how do you actually reach an organ through a vein or an artery? Like, do you have to make a hole once you're inside, right? You obviously have to make a hole to get inside, but once you're inside, do you have to make another hole to get to where you need to go?
No, it's a great question. Actually, that brings me to this slide. So we use a hole to get in wherever we're going, whether it's a bile duct, a lymphatic, artery, a vein, whatever it is. And we can use a couple things. So here's an example where we can use X-ray. And you can see a catheter that's actually in the aorta. And I know that the arch vessels live somewhere there. Mm-hmm. And so I can use my catheter to try to get into one of these arch vessels or go down and try to get into the celiac or SMA or whatever it is I'm doing. And so I have tactile feedback because I know I can feel when my catheter's engaging a vessel, and I can also look at it. Also, a lot of times we don't have to go through a blood vessel at all. We can go straight through the body. So, for example, under ultrasound guidance, we can stick a needle through the skin to wherever it is we need to go, whether we're trying to ablate, which means to destroy a tumor. We can just go through the tissues there. Here's an MRI. So basically any tube we can open up, from the fallopian tubes to the arteries, to the veins, bile ducts, ureters, intestine. Again, we deal with every part of the body. Here's some basic tools for our audience. Here, let me hide that, sorry. Basic tools, we use stents and wires and catheters and everything sort of over a wire, over a catheter that we can follow. And so to the person who asked this question, so once I'm in the artery, I can inject X-ray dye and see where I am. So I won't quiz anyone, but this is the celiac artery, and you can see there's a splenic artery, there's a left gastric artery, and then there's a common hepatic artery, and here's a vein. And so we sort of roadmap where we're going. And again, we have different tools. These are all the toys, the angioplasties and stents and all the fun things you get to deal with in IR.
That's awesome.
Yeah. I'm going to show you some here. So, and again, not just through the blood vessel.
Let me ask you a quick question.
Yeah, please.
Based on kind of understanding where you're at. Obviously, you're looking kind of those imaging, it's kind of live X-ray, right, of what you're seeing. I know in the orthopedic world, we're doing 3D reconstruction of bones, so I know what the bones are going to look like before I even go in. Is that a technique potentially used in the IR world where, hey, I'm going to do an MRA and look at the whole body or wherever I need to go so that I know where I'm at, and then the patient's on the table that align to a specific marker so that I know based on the data from the MRI, based on where the patient is on the table, based on where my catheter is, exactly to the millimeter where I'm at. Is that technology that we have?
Yeah, so that technology you're talking about with orthopedic surgery, that's all radiology technology. Mm-hmm. And since our best friends are diagnostic radiologists, the dirty secret is we get it first. So absolutely, we have that technology. We have things called fusion imaging, where you can actually take a CT or an MRI and fuse it, sort of overlay it on the screen. And there's a lot of interest in decreasing radiation that way. So instead of live X-ray, well, if the patient already had a CT or an MRI, maybe I can overlay it well enough that I don't even need X-ray at all, because I can just trace the CT or the MRI over the patient. Yeah. On top of that, we have things like on the table, you can do a CAT scan on the table. So if my catheter is in a patient's adrenal gland, and I'm like, oh, I got to make sure it's in the right spot, I can do what's called a cone beam CT, a CT on the table, and prove it. Same thing with chasing tumors. Make sure we're actually killing the right tumor as opposed to normal liver tissue or something like that. So yeah, all that technology, again, my training's in radiology. So while I'm not a diagnostic radiologist, my background's pretty solid. And so all this neat imaging technology is at my disposal on top of the clinical and interventional ones.
Nice. Are we getting to a point of Elon Musk's self-driving technology where you make the hole and you stick the catheter in and the device goes where it needs to go automatically?
We're not there yet, but that is absolutely something that's being worked on. I mean, they have robotics. They actually have a lot, that are now FDA approved, robotic catheters. And that's certainly where we're headed to some extent.
Nice.
Yeah.
That's the kind of stuff I like.
I know, right? It's all about the until they take over. I mean, yeah, Skynet, right? We got to look out for the Terminator. But here's a cool sort of image where this is something where CT would be very helpful. Instead of going, this is a tumor on the kidney, and so again, the option is to cut the patient open, or even laparoscopically remove part of the kidney or the whole kidney. Well, the alternative is, we could, under image guidance, directly stick that tumor with some sort of heat, microwave, cold, something, and either freeze it, burn it, irradiate it, in some cases in the liver, until you kill the tumor. And for some kidney cancers, this is as good as open surgery. And so again, this saves a patient from, all the sort of risk and complication from an open surgery. And it's, IR is what we like to call precision medicine. So instead of just lobbing off half the kidney, we are literally just taking out the part of the kidney that is tumor and leaving all the rest of the kidney behind. Same thing with a trauma. If you have a trauma patient's bleeding to death, instead of cutting out the whole organ, just take out that small artery that's bleeding and leave the entire organ intact. And so that's a nice example. So
what you're saying is that was a tumor, and then it's not a tumor.
Is not a tumor. Yeah.
Somebody said loving these movie references, so I'm going to try to.
Oh, good. Yeah, I was going to say. I figured most people on right now have no idea what we're talking about.
It's not a tumor.
Before we were born. Yeah.
Yeah. Interesting.
Yeah.
So the training path, you mentioned it, but it was pretty brief in passing in terms of the change in where interventional radiology training has gone from a diagnostic radiology to fellowship to now its own residency. What does that residency look like now?
Yeah, it's a good question. So, I mean, the truth of the matter is we were fishing from the wrong pond. Diagnostic radiology is such a good field and such a good specialty. It is just so different from IR. And so what we used to do is we used to take these diagnostic radiology, we used to take these interventional radiologists, make them do a diagnostic radiology residency after 5 years, and then put them in IR. And they're like, well, my goodness, I wanted to do this 5 years ago. So now the training pathway is same time. It's about 6 years, but IR is longitudinal throughout the entire thing. And because, the diagnostic imaging portion is such a crucial part. I mean, part of everything I do is image guidance. And so my ability to understand MRI physics and CT and fluoroscopy is really quintessential to my job. You still get the diagnostic radiology training. It's just de-emphasized, compared to a full-on residency. And IR is longitudinal. In addition, we weren't doing a great job with the clinical management. So IR physicians are clinical physicians. They, we've got clinic. You've got to manage your patients. The days of just doing an awesome procedure that no one else can do and then sending them away to someone else to manage, that's over. You got to be able to manage your own patients, to some extent. Obviously, we have specialists as well. But so the training pathway includes ICU, includes some surgical rotations, includes longitudinal IR throughout, and then also some imaging rotations as well.
Yeah. So people are still confused here. I don't know why. So IR residency is 6 years, period, right? It's not 4 years of this plus a fellowship. It's just a 6-year residency.
It is a 6-year residency. Yep. And the only exception would be if you wanted to do neurointerventional, that's additional training. Yeah. Or if you started as something else and wanted to switch into it, which is true for anything.
What are some pathways into IR from something else?
So the most common is that someone starts as diagnostic radiology and says, whoops, I actually want to do interventional. But, we get ENTs and surgeries and general surgeries and, all sorts of people who switch.
Yeah. Garrett here is calling you the viceroy of the veins and trailblazer of the tube.
Love it.
Yeah. Prince of the pipes, maybe. I don't know. No. Right.
No. Sounds like it should be an opera singer with the Prince of the Pipes.
There you go. So talk about something that maybe isn't talked a lot about is needing to convert to open. How often, if you're doing something, does something need to convert into open? Meaning the surgeon has to come in to clean up a mistake or something wrong or just something you weren't prepared for.
Yeah. So So the way you ask the question, I would say the answer is very rarely, almost never. And that's not because I'm awesome. It's because our tools have gotten so good. So for example, if I have an artery perforation, back in the day, you have to call the vascular surgeon and say, can you please open it? Now we've got stent grafts. And so we can clean, sort of fix it, endovascularly.
Not flex. Is that flex tape? The water, and he gets that flex tape and
yeah,
it on. And like, oh, it stopped bleeding.
Yeah, we ordered it on the TV. We thought it was good enough for our patients. It was an awesome special, $9.99 too. Can't beat it.
As seen on TV.
As seen on TV. So no, I mean the tools have gotten so good now that very rarely. Now that is in no way, shape, or form to say that we are not so grateful for our surgeons. And that most often happens where I have a patient who says, you know what, I can treat you or I can fix you, but I think they can do a longer lasting job. And that's fair. And to be honest, and I think that's true of any specialty, we have to rely on each other. My wife's a gastroenterologist. There are a lot of things she can do. There's a lot of things where she says, you know what, we need the GI surgeon for this, and vice versa. A lot of my referrals are from surgeons who say the opposite. I can do this, but I'm going to have to crack the patient's chest. Can you fix them through a small hole? And I say, yes. And so we rely on each other a lot. And I'm so thankful for my surgical colleagues and my medical colleagues. But in terms of, I need a bailout, that doesn't happen that often anymore. Knock on wood, of course, now that I've said that.
We're all knocking wood.
Yeah, exactly.
Do you see a world, and obviously you're one specialty, and so it's hard, but do you see a world where the cardiothoracic surgeons are only doing transplant? Because obviously you can't do that.
I don't. Open surgery has endured long enough that I think, and there's some smart, women and men in those fields that continue to engineer and pioneer. And so I think I know what you're saying. They're saying, well, everything's becoming minimally invasive. What is the cardiothoracic surgeon going to do? But I still think at the end of the day, there are things that are going to be better with open surgery. Yeah. Maybe I'm wrong, and maybe 25, 50 years from now, that's not true. But for the time being, I think our surgical colleagues are so appreciated and have enough work to do. But yeah, there's no question things are going more minimally invasive. I think that's right.
Yeah. Interesting. All right. Well, you have a case for us?
I do. So you asked me, can you focus on one thing or another as a specialty? Mm-hmm. So the answer is yes. So I tend to focus on vascular disease. So I treat a lot of patients with peripheral artery disease, patients who are going to lose their leg, patients who are on dialysis and need way to dialyze or have blockages in their SVC right above their heart. So I focus on vascular. So this is one of my patients. And I don't say this lightly. He is one of my favorite patients of all time. And let me put this here. So this is my case. And this is not a technical talk, so I'm not going to talk about stents or anything too crazy. This is a story about Garth. And the reason I always like Garth is, I basically treated him from 2014 until 2018 or 19. Every single, 3 to 6 months, I'd see him in my clinic. And the reason is, he had these ulcers. He would have these ulcers that pop up. And he was such a soft-spoken guy, and he would always come in with his wife. They seemed like they were married for somewhere around 300 to 400 years. One of those people, like, finish each other's sentences and just clearly, like, they were the world to each other. And he used to call me Mark, and I would call him Garth, and be like, I'm like, Garth, how you doing? Mark, I'm good. I mean, think the ulcer's smaller, and when these ulcers would pop up, we would treat him, and he would heal, and then they would come back, and we would heal, and this is a guy who someone recommended amputation. Let's just cut off his leg, which I think would have devastated him. And we know quality of life and mortality goes way up after an amputation, so we were able to save his leg over and over and over again. And here's an example. Here's an arteriogram. And you can see these are this black is blood vessels. And you see he's got narrowing in his blood vessels. This is his thigh. This is his leg. But actually, if you look at his foot, the back of his foot, he's missing all this blood flow. Mm. And so for this, for Garth, I did something that, is pretty sophisticated and novel, even though, more and more of us are doing it, is I actually was able to get around his foot and thread a small wire, 0.14 thousandths of an inch, all the way up, and open up that blood vessel. And you can see by the end, he had all this blood flow to his heel. And that's how he would heal these ulcers. That we would do these procedures and open these arteries that, again, surgery, you can't open that with surgery. I mean, you can't bypass to the plantar surface of the foot and expect it to stay open. And so this is something that only, interventional endovascular work. And he would heal these ulcers and do great over and over and over again. And then I remember one time in July, he had a new ulcer, successfully treated. And then a month later, I'd see him. And I called and I said, he didn't show up to his appointment. I said, once I emailed my clinic, and unfortunately they gave me this, which was he died. And I called his wife, obviously pretty broken up about it. And she just said, thank you for everything you did. He had his legs till he died. And he loved you. And I know how much you cared about him. And so, when people think about radiology, I don't know that they think about those stories. There is no way that I knew I would be happy treating someone's blood pressure for 40 years in a clinic or managing diabetes, something else. But, having these relationships and also doing awesome, cool procedures and being part of someone's life like Garth was pretty cool for me. So that's something that I think I'm going to remember for the rest of my life. And I actually do miss him because we used to see each other every 6 months.
Is that a common thing in your specialty to have those long-term relationships?
It is. I mean, most of us, if you're not treating vascular disease, most interventional radiologists will be interventional oncologists, treat a lot of cancer. Mm-hmm. And so those patients are ones that surgery often is not good for because their tumor is, not necessarily resectable. And so they treat them and they come back and they treat them again. And they have these discussions like, unfortunately, the tumor's back or the tumor looks worse than I saw you last time. And so they do have these longitudinal relationships. Absolutely.
Yeah. The recurrence of the ulcers, there's lots of questions about kind of what's going on there. Is that just vascular disease, just bad genetics, or diet, exercise, all the normal kind of things? All the normal kind of things. There's certainly patients who, it's, high cholesterol and diet and exercise, heredity, but what I tell patients all the time is once I open an artery, it behaves like an artery, which means it can re-narrow and re-block. Now, most patients, their ulcers don't come back. Once you heal it, they're good. But there's patients who, we treat it, they heal, and they come back. And there's patients we treat it and they just don't heal. And we have to have those conversations with them as well. Yeah. Amazing stuff. I want to bring on some students for some Q&A. How's that sound?
Yeah, awesome.
All right. So if you want to come on, say hello.
Be gentle. It's late at night.
Raise your hand. A few questions came up earlier in terms of work-life balance. It seems to be more and more important with younger generations. What does that look like for you? When you're on call, do you have to come in? Are you just in the hospital all the time? What does that look like?
Yeah, so it really is practice specific. So for example, I happen to cover a level 1 trauma center. That's one of the major transplant centers in the entire state. So when I'm on call, it can be busy. But if you want an office-based lab where all you do is see outpatients, 9 to 5, Monday through Friday, that is an option. So you can sort of manage your practice how you'd like it. In terms of work-life balance, you know what? It is so personal in terms of name whatever specialty you think has the easiest lifestyle. And I guarantee you there's someone out there who's busting their butt and hard to see their family. Yeah. Pick whatever specialty you think is the hardest lifestyle. And there's someone who's doing it right. It's not easy. My wife's a physician. We've got 3 kids, but it is absolutely doable with very good patient satisfaction, very good family satisfaction. You gotta, it's like anything. You gotta find mentors to sort of show you how to do it.
Yeah, I think that's the biggest thing that I've come to learn over the years is once you have your degree, once you have your training, you can craft whatever life you want. Yeah. Now, obviously, if you want to work 3 days a week, you're not going to make as much money as someone who works 5 days a week. And so you need to adjust your lifestyle based on that. That's the amazing part of medicine, is that you can do anything you want. Now, can you go work in a major academic medical center 3 days a week? Maybe, maybe not. But can you find a private practice that would love to have you 3 days a week? Probably. Yeah. It's just lots of questions asking and being intentional about knowing what you want and then crafting that life for yourself.
Yeah, I would echo that. I used to have an attending who said, he was in private practice for a while, and he used to work with people. And he said, I mean, these people would work like dogs and be poor because they wanted everything. They wanted the big house. They wanted the thing. They wanted, and they wanted to, not be with their family or be with their family, whatever it is. It's your choice. You're not an NBA player, so you probably can't have it all. But if you're judicious and smart and sort of value some things, not everything, you can have a great lifestyle.
Yeah. One other quick question, then we'll jump into some of these students here.
Yeah.
Just because the way that my brain works, I love thinking about problems and how to solve them. Is the IR world ripe for people to come in and invent new technologies and find better ways to build a mousetrap? Is the kind of industry of devices perfect for IR people?
I don't know of a specialty that's more suited for it.
Yeah.
We are a 50-year-old specialty. You walk down the halls of Hopkins and see how old the surgeons are. They've got 300-year-old pictures there. We are a baby specialty. We are innovating every day. Everything is minimally invasive, sort of new technology. We are ripe for it. The other thing, Ryan, before I leave, the one thing we're not good at, and you mentioned work-life balance. One thing we're not good at is getting women in our field. We do not do a good job with that. That is changing. And I think part of it is a lot of myths, radiation, too much call, work-life balance, whatever it is. I think a lot of that has been true in the past. I think a lot of that is absolutely getting better. And we are becoming more cognizant that our specialty is doomed if we don't get diversity. And there are so many sort of brilliant women and a diverse population that are so good at IR, and don't let the fear mongering stop you. If you're a woman or whatever it is, a minority, person of color who's interested in this field, find a mentor because it is awesome for you.
Nice. Good words to live by for everything.
Yeah,
Shane, say hello.
Hi, how's it going?
What's happening?
Not much. So I'm trying to picture some of the logistics of actually doing, these like wire movement and things like that. And I'm I'm picturing okay, I drop something between the wall and my bed. I only have a foot distance there, but within the body, there's a huge distance between some of the vessels that you're trying to reach, and the maneuverability when you're trying to wiggle a wire in there is I imagine very difficult to actually maneuver with much precision. Is there a minimum or maximum distance, when you're deciding where to enter and where you have to reach? How do you figure that out?
Okay.
I can barely get a hanger and a t-shirt. How am I supposed to get it in that vessel?
Right.
So first of all, it's such a good question that I demand your application to IR right now. Okay. Second of all,
Shane, just so you know, Shane is the fan favorite of the group.
Nice. Awesome. All right. Well, hopefully we'll win. But so the answer is no. I mean, there are cases where you literally access the radial artery in the wrist and make it all the way down to the pelvis or leg.
My goodness.
And in some cases, you can actually access the wrist, access the foot, and have a wire that's coming out the patient from one end to the other. We call it body flossing because it's like a floss.
Wow.
And so, but that said, the science and physics of wire manipulation and movement and torque and pushability is something you need to know as an interventional radiologist. And so, I know that if I'm going from the wrist and I'm working in the pelvis or the thigh, I got to be cognizant of what wires and what wire properties I choose, because I am going to lose torque. I am going to lose. Now, the technology is so good that we can compensate in different ways. But yes, that is part of what I'm thinking about when I do a case.
But there's no, you can go anywhere.
You can go anywhere. There's nothing. There's no part of the body you can't reach with a 22 gauge needle and a stiff arm.
I'm
like
impressed.
The Pan-American Highway. Just
Absolutely.
goes across the whole thing.
Yep. Yeah, pick up a journal of vascular and interventional radiology and look at the either extreme IR or case report series at the end, and you'll read it and you'll be like, wait, what? Like, I do that still, and I'm, been doing this for a little while.
Is there a number out there, like the longest catheter that's ever been inserted?
I'm sure there is.
Get a Guinness World Record.
Yeah, I'm sure there is. I mean, we have 170 centimeter catheters. Don't ask me to convert it to English because, and one of the craziest stories is, I don't want to give it to the wrong person. I think it was Charlie Dotter who invented our specialty, who was giving a talk once about catheterizing veins, and everyone's like, "That's insane! You can't do that. You're crazy." And he's like, "Well, I can do that. In fact, I gave this entire talk with a catheter sitting in my heart." And keep in mind, that was the first time anyone ever done that. And he lifted up his arm and he's like, "See, I've got this catheter going all the way." So maybe he was a little crazy. But yeah, they've been doing it for 50 years.
Yeah,
that's incredible.
Yeah. He said, "Hold my beer" to the dude who ate all the H. pylori.
Yeah, exactly.
That's awesome. All right, thanks.
Thank you so much.
Yeah, thanks.
So, solve this for me now. Trusty says, "I feel like interventional radiologists are excellent parallel parkers."
Oh man, I wish that were true. I grew up in Florida. We didn't even have to parallel park on our driving test.
That's true. You got grass roads everywhere.
Yeah, everything's a strip mall.
Where in Florida did you grow up?
Fort Lauderdale.
All right, I'm a Tampa boy.
Oh yeah, different world.
Justin, say hello.
Hello.
Hey.
Hi. So, I think I have a million questions, but I'll just ask one.
You only have time for 900,000.
So this really does seem like this is a bit of following up on Jane's question, but a lot of IR does seem like having a sleight of hand that you would expect in a field like surgery. What advice would you give to someone who seems interested in it but might be on the clumsier side and doesn't have the sleight of hand to insert a catheter through a vein?
Yeah, so I'd ask you, when you were first born, how was the walking? Right? So you were probably pretty terrible at it, but it's a learned skill. Are there people that are so clumsy or uncoordinated? Yeah, probably. But don't count yourself out. Everything's a learned skill. You couldn't even feed yourself for the first 3 years of your life, right? So come on. It takes time. So all those, the beauty of IR, I remember when I was, my first job, I was watching one of my senior partners, and the way she would teach a case, I mean, literally, she would say, "Okay, now turn your wrist counterclockwise X number of degrees, and now turn it again the other." And I'm like, oh my goodness, that is a level that is so far beyond me. But actually, you get there. You know the hand motion in order to get into the splenic artery. You know the hand motion in order to cross a blockage. I know exactly how that feels, but I was not born with that. That is a learned skill. So if you're passionate about it and you're willing to put in the work, keep going.
That's what this game is for.
That's right.
Practice, lots of practice. Don't touch the sides.
Yep. Only we need one with radiation. So when you, instead of buzzing, it actually irradiates you.
Love it. Thanks, Justin.
Thank you.
Absolutely.
Amy, hello.
Hi, can you hear me?
Yep.
We can.
Okay, so I have two questions. First of all, what inspires you most of all to go into radiology? And then number two, if you could change one thing and to make the field better, what would that be?
Oh, good. So the easy questions, basically. Yeah, those are hard. So what inspired me most? If you take the time to meet radiologists in the hospital, they are the smartest people. I remember I was a pretty good medical student. I paid attention. I was interested. I remember my first month of radiology, they would be talking about things. And it's not like, oh yeah, I remember studying that for the boards and I just forgot it. I had never heard the words before. I never heard the diseases. And they talk about it like the common cold. I mean, you have to know everything in radiology. And so that inspired me to sort of enjoy radiology. But then at the end of the day, I wanted to do something with my hands. I wanted to have a direct sort of procedural impact on patients. And so it was a pretty cool combination. In terms of what I could change about IR, again, we're only 50 years old. And so this model that I tell you about, which is we have clinic and sort of watch our patients and manage our patients correctly, that is where we are now and where we're going. Unfortunately, we still do have some proportion of interventional radiologists from the old school that are not on board with that. Now they're being phased out and retiring and all that, but sometimes you still get that. And so I think in the next 5-10 years, it'll be a non-issue. But this idea that an interventional radiologist is a clinical specialty that takes ownership of our patients and does the right thing, is here to stay.
Nice.
Thank you.
Thank you.
Thanks, Amy. Last but not least, Daniel, hello.
Hello, can you hear me?
We can.
Okay, yeah, I just had one question. So kind of like, in open surgery, they put the patient under general anesthesia. Mm-hmm. Is it common, like for like an angioplasty, are they going to be under general anesthesia, or have you done some where they're just like actually awake?
That's a great question. So the motto in interventional radiology is faster, safer, better. So most of my patients are not under anesthesia at all, are not under general anesthesia. So we do it with moderate sedation, Versed and fentanyl, which is just a sedative and anti-anxiety medicines. Sometimes we even do procedures with just pain medicine and local. And so we can do all these things because, again, we're not cutting them open with minimal anesthesia, which is obviously safer for the patient and less expensive for the patient and the system.
Oh, that's cool. So just because you're not doing a really big incision, so they don't have to put under the general anesthesia.
Correct. Yep. Absolutely. Now, every once in a while, we do use general anesthesia, but it's the minority of our patients for sure.
Okay. And then do you have time for like one follow-up question?
Quick.
Okay. Yeah. So like, there's a stigma, I think, around maybe minimally invasive procedures because, you said doctors are saying, that's crazy. How long do you think it's going to take for doctors, kind of just general doctors to kind of accept that this is also something that can be an option besides open surgery?
Yeah, that's a great question. I think it's on us to provide the data and to get out there and educate. The worst clinic visits I have in my life is when I see a patient who has been told nothing can be done and they come to me and either I can do something or we've missed that window and I knew I could have done something 6 months ago. But that's on me. I got to get out there and educate referring doctors. They are internists, family practice doctors. They are busy. So that's why I'm big on education.
Okay. Thank you.
Yeah.
Thanks, Daniel. That's the kind of nerd that I am. Is you say it's on you. I say it's on our system. Our electronic medical record system has enough data so that a surgeon, a primary care doctor, whoever it is, puts in a diagnosis, puts in enough keywords that the system goes, bingo, 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 this is an IR thing.
Yeah.
And sends a note to the doctor or you or whoever. It says, hey, have you thought about interventional radiology? Here's some articles to look at. That's where I hope we go in the world. And I think some physicians will hate that because they're like, you're taking all the thinking away. And I think it's just giving you freedom and flexibility and comfort to know that you're not missing anything. That things that are being missed now because someone isn't thinking about it or they don't understand the new standard of care or whatever, all of that will be able through Epic, because Epic obviously is going to run the world, to say, hey, have you thought about?
Yeah. The hardest thing in medicine and life is not knowing what you don't know, right?
Yeah.
So
that is it. Well, Dr. Mark Lessne, so much. Thank you so much for coming, hanging out with us tonight and taking some time away from the family. Appreciate it. And the 700 or so students that were hanging out with us live, appreciate you as well.
Yeah, man. Awesome. I appreciate everyone tuning in and thanks for having me.
Everyone have a great night and we'll see you soon. Bye.
Bye all.